Hi, everyone. Welcome to today's webinar. We hope you enjoyed a little bit of background music as you guys waited. So thank you for joining us today. Today is the last of a three-part, well, not the last of a three-part series, but we've developed a webinar series, and we're really excited to bring you this third installation. It's Emerging Strategies to Address SDOH Through Community Referrals and Cross-Sector Partnerships. Next slide, please. So just some housekeeping. Just for all of you to know, this webinar will be recorded, and any relevant resources and next steps will be available and emailed afterwards. I'll go through a little bit of housekeeping on tips for Zoom, but I think at this point we're all pretty zoomed out and understand how to use the features within the platform. And finally, want to acknowledge our new realities within this world. So we've got kiddos, furry friends, unstable internet, and renovations, and Lord knows what else happens in 2020. So bear with us if there are any technical difficulties. Please, if you do have any technical difficulties, please be sure to chat one of the panelists, and we'll be sure to answer any of your questions. Next slide, please. So again, these are just some of the features within Zoom. You have the capacity to submit a question through the Q&A platform, which is really great because it allows us to see what other questions that you have, and then we'll be able to answer them once we get to the Q&A portion. But you could also feel free to use the chat portion. You can chat with any other attendee or with the panelists. It's really up to you. So these are just some mechanisms to engage with us. And please, if you're obviously, if you need anything, please be sure to raise your hand in the platform. But hopefully we should have a pretty smooth experience today. Next slide. So we're gonna launch a quick poll right now just to get a sense of who's in the room. So you should be seeing 2 questions pop up really soon. Let's see. Someone can launch the poll. I don't have access to that right now. I'm sorry. So there should be 2 polls.
Yep, it should be up. People are now answering. So
okay.
Let me.
Great. So the first question is organization type, and then the other question is we want to know what screening tool you're using to collect social risk data on patients. Knowing that there's many tools out there, we wanted to get a sense of who's in the room. And Albert, whenever you want to close the poll, just let me know.
Yeah, do it in 10 seconds. Just
all right, wonderful.
Getting we have 59% of the audience voting, so that's pretty good. All right, it's getting closed now. Thank you all.
Great. And thanks, Sarah. If the screening tool is not listed, please feel free to chat it. We'd love to know what other screening tools are out there that folks are using. So please be sure to share. All right, so these are the, this is the agenda for today's session. So I'm Eureka de la Cruz. I'm the Social Determinants of Health Manager at NAC. I'm doing some very high level opening and housekeeping right now. I'll go into a little bit about how health centers have been using SDOH data to create cross-sector partnerships. And then we'll hear from our guest panelists today, which we're really excited about. So we'll go a little bit more into detail with that, but we definitely want to save a good portion of today's session for our Q&A session at the end. Where we'll have some great engaging dialogue with the panelists, and then we'll hear from you all to see what questions you have and you want to ask the panelists. Next slide, please. So this is our project team at NAC and at AppShow. This is the team, and I don't want to introduce everyone, but there's one person that's missing. It's Nalani Tarrant. She's our new deputy director. She joined our team a couple weeks ago, and she's jumped right into the mix of things, and so we're happy that she's on our team. But we are here as a resource for all of you. So just please, this is the team, and we're here happy to help you all. All right, next slide. And then this is today's panelists, and I'm going to do a quick overview of their bios. So first we have Arteret Rogers. He is the California Program Director for Health Leads, actually Director of California Program at Health Leads. In his role, he oversees the development of resources and technical assistance aimed at equipping healthcare organizations, community-based organizations, and other anchor institutions with tools to develop and implement interventions within their communities that address both the social determinants of health and the systemic inequities that create racial health disparities. Additionally, Arteret leads the West Coast Community Partnership Portfolio and partners with communities to develop community information exchanges and spearheads sector-level dialogue focused on integrating equity frameworks and commitments into social need care delivery. Prior to his role at Health Leads, he served as senior consultant for the Southern California region of Kaiser Permanente. Next speaker that we have is Lynn Salazar-Wadford. She is the Director of Care Management at Piedmont Health Services, which is in North Carolina, and it is the oldest federally qualified health center. And the system includes 11 health centers as well as 2 PACE facilities. She and her team work within PHS as well as alongside with community partners to ensure patient connection to the resources they need to maintain and improve their health. This includes working with populations such as refugees, LGBTQ, and HIV positive folks. She has served as co-chair with Orange County Refugee and Immigrant Health Partners and is current member of the Orange County Health Equity Council. Lynn has also worked with WIC, the Women, Infant, and Children Program, and with Orange County Partnership for Young Children. And finally, but certainly not least, we have Jen Medeiros Costello. She's an independent health and human services consultant, currently contracted to co-lead Embrace, which is a cross-sector effort addressing equity in birth outcomes in Chatham County, North Carolina. Most recently, Jen served as the Director of Strategy and Planning at Piedmont Health Services, same organization as Lynn. In that role, she worked with stakeholders across the organization to develop, evaluate, and implement the strategic plan, as well as initiatives related to ensuring health access, including Piedmont Health's implementation of PRAPARE, its preparation for Medicaid managed care, as well as refugee and LGBT programs. She has also worked in Washington, D.C. as a consultant to the Federal Head Start program and at the United States Department of Education Office of Safe and Drug-Free Schools. Jen has a master's in maternal and child health from Harvard University School of Public Health. So that's a snapshot of our speakers. We're very thrilled to have them here today. Next slide, please. And we wanted to acknowledge that the support for this webinar is provided by the Robert Wood Johnson Foundation. We're really excited that we've partnered with them to bring you all this webinar, and we wanted to thank them for their support. Next, please. So this is from the Robert Wood Johnson Foundation, and I'm not going to spend too much time on this, but this is the theory of change that they've come up with in terms of how do the different sectors of healthcare, public health, and social services work together collaboratively to achieve improved health outcomes in the communities. These are the different elements that go into this type of work. We just heard from them yesterday that they've updated this theory of change, so we won't spend too much time on this. However, we wanted to at least share the why with developing this webinar series. Next, please. So again, this is part of a webinar series, and this came about as we heard from our stakeholders that they wanted to learn more about community partnerships. So this is through a survey and a community conversation where we heard the needs of PRAPARE users, but more so the different people that are out there collecting social risk data on patients. Next, please. And for your convenience, these are the slides, or actually the links to the slides in the webinar recordings to the first 2 webinars. So if you missed them, these are the links. So please feel free to check them out when you have a chance. And then, all right, I'm going to dig in a little bit into this section in terms of how health centers have been using SDOH data to think about and to create cross-sector partnerships. Next, please. So when we think about data and how this data is collected, there are different levels, right? Obviously, this information is collected at the health center and it's used individually for patient care. We have a lot of health centers that have been able to use this data to then think about how do they utilize their care team members, how do they better manage the needs of their patient and the population that they serve. And then also health centers have looked at how do they create different cross-sector partnerships to address these issues. So this is just a visual. It's always nice to have a visual to see how the data works and how we're able to use this data. So it's collected at one time, but there's different players that access this data, but more so leverage this data in a very powerful way. And so the part that we want to focus more in this session is the middle part in terms of community local health system transformation. How do we really look at this data and say, how do we make the changes in our communities so that we see different outcomes? Next slide, please. So this is an example of how the interventions look across the continuum. So in this middle, in this sandwich, if you will, the middle part where we're identifying social risk factors, this is the collection of the data at the health centers, right? And then that data, most of the times, we're able to use that data to address our patient needs, the social needs. So that's considered a downstream strategy, right? How do we work with community health workers, social workers, housing advocates to link our patients with the resources that they need to get the different services or resources, right? But then this information can also be used in upstream efforts. And by that, I mean, how do we look at the systems or the policies within the community that are creating these outcomes? These outcomes are not occurring accidentally. So we have to see what are the ways that we can make some changes systematically so that we get different outcomes. Because if we don't change the system or the policies, we will continuously get the same outcomes over and over again. So in this diagram, we're looking at how do we advocate for policies that could possibly promote for housing stability. It looks at affordability or supportive services to protect tenants. Also looking at food security as well. So these are just some examples of seeing how this data is leveraged upstream, but then individually in the downstream efforts, if you will. Next slide, please. So I wanted to share this example. This is from the PRAPARE Round 1 Train the Trainer Academy case studies back in, I believe it was 2017 or 2018. And this is where partnership with the statewide primary care association or even a health center control network is really powerful for health centers, right? So as a health center, you're collecting this data, but if you partner with a primary care association, this information can be leveraged in a very powerful way. So one thing that the Indiana Primary Healthcare Association was, they formed 2 partnerships, one with Indiana 211, and that's where they were able to see how they could create a referral sharing source or system, if you will, of creating the referrals, having the health centers refer out, and then how do we close those referrals for our patients. And then even more interestingly enough was the Michiana Health Information Network, which then was able to use this data to say, okay, this is how we can use, this is what's happening in the community, this is how we can assess the needs, and how do we allocate resources accordingly. So this is just an example of how this patient level data could be used for upstream efforts. So you have a 211 partnership and then another partner that's able to visualize and aggregate the data in a way that's very powerful for resource planning and strategizing as well. Next slide, please. And I'm not going to spend too much time here, but this is looking at the same visual that I had earlier. Just wanted to provide some concrete examples of how of how our PRAPARE champions have been able to use the data that they've collected at these different levels. Obviously, SDOH data is general, but with our PRAPARE users that we've worked with, these are just some of the findings that we found. Next slide, please. And I think at this point, wonderfully enough, we'll be hearing from Arter, our first guest speaker. He's going to talk about the amazing work they're leading out in California. And so right now I'll turn over the mic to him.
Thank you so much. Just want to give a special thank you to NAC and APCO for having Health Leads in this webinar series. And really the level set that was just provided that talked about how data can be used in cross-sector partnerships is something that I'll be touching on at this moment, particularly how to steward social determinants of health data in an equitable way. Before I get into that, just to give you a little information about Health Leads. Health Leads is an innovation hub that runs both national and local initiatives that address the deep societal roots of racial inequity that impact our health. And especially during the COVID-19 crisis, we've seen Black and Brown communities disproportionately impacted due to structural racism. Health Leads work has focused on helping communities both respond to immediate essential health resource needs and rebuild equitable systems for the future. And as we begin to rebuild systems, we must ensure we're not replicating or reinforcing the deep inequities in how those health, justice, education, as well as other systems operate. And we need to do this intentionally and explicitly uplift racial health equity. So if we go to the next slide, I'm going to talk about this in a use case study. And this is really focused within Contra Costa County, a county in Northern California within the Bay Area. And before I delve into what the community information exchange or what that build is looking like, I just really want to, again, do some grounding around COVID-19. And with COVID-19, we started engaging with Contra Costa Health Services, a deep partner with Health Leads, about responding to the needs that was present within the county. And oftentimes, when we talk about COVID-19, we focus on the curve of cases and really look at the death rate that is associated with COVID-19. But there was another curve that this health system was looking at primarily as well. And that's the curve that was focused on the total demand for social services. And they were comparing that to the social service capacity within the COVID-19 crisis. And as you can imagine, accessing resources during the height of COVID-19 and is even now was extremely challenging. And what we started to see was the fact that these disparities that we talk about from a healthcare sector, from a social sector, were exacerbated even more. And this is something for us to just really ground ourselves in, is that at baseline, the US has large racial disparities across health outcomes, food insecurity, income, and access to adequate housing and education. So when we were looking at the unemployment levels during the height, the first wave of the COVID-19 crisis, we started seeing unemployment levels that actually rivaled the numbers of the Depression of the 2008 and also the 2008 recession. And although we're seeing many jobs being recovered, there's still millions that are still lost. And we really don't know what the third wave of COVID-19 has in store. And I know that this sounds grim, but even again, with the disparity in unemployment levels, if we look at the 2008 recession, we saw that unemployment levels really showed the same disparities around race, gender, education level, socioeconomic status. And it became clear that we cannot just focus and operate in the systems that help perpetuate these disparities, and I guess at best reinforce these disparities. And I know this sounds grim, but this awakening really fueled Contra Costa Health Services' desire to do something different. And so in our partnership, we really wanted to come together to think through how can we collect social determinants of health data? How can we provide information on essential resources to the people who are at most need? And with that, a desire to really think through how do we recreate the system that's not working? So how do we create two streams of work, one focused on responding to the need, but also thinking through how do we recreate, reimagine the system, was the focus of the Contra Costa work. And so the glide path to begin discussing the community information exchange really started in partnership with 211 Contra Costa. And it was using their existing platform to provide information around resources in real time for the people in Contra Costa County. And what we're seeing is that not only did we need to talk about providing the information, it was really facilitating discussions and creating the processes to enhance connection to these resources. So oftentimes we hear stories of patients who or community members who are going into the community looking at resource information, but are not connecting to the resources that they need. And this was of vital importance when the whole county and the whole state was under shelter-in-place orders. So how do we, even in a virtual setting, create new processes to ensure that people are getting the resources they need in a safe way? And so the first thing we had to do was build a foundation of trust. So we knew that community-based organizations had a relationship with one another, but oftentimes there are still disparities even in processes between each other, and also how community members received the respective resource. Then we really had to talk about the tools and processes needed to make sure that people were able to connect to the resources. And lastly, how do we hear from the community in real time? What are the most important needs? So that was the process of centering community. So we started understanding that those were that was the foundation needed to create any type of information flow around connections to resources. We are now using those principles to create a more sophisticated version of information resource database, and that is the Community Information Exchange. So the Community Information Exchange has these components. So the resource database, which is coupled with closed loop referrals. So how do we make sure that the processes are in place that ensure that people connect to the resource? To make that happen, there is a lot of focus on individual care coordination and referral experts who can walk people through the process of connecting to that resource. Now, we've heard about this process in many ways. There are a lot of technology solutions that facilitate information flowing from the health system to a community-based organization. But what we started to understand as we started looking through the literature is that we were seeing a drop-off in acceptability and adoptability within the community. And the reason why we felt that that was happening was because there was a lack of community governance as well as an anti-racism focus. And so I'm going to speak a little bit more what I mean with the anti-racism focus. A lot of times we create social determinants of health interventions in a savior-based way. So we, as professionals, understand the needs of the community. We feel we understand the needs of the community, but we go about developing intervention, a lot of times not including the affected population in the design of the processes. There's no decision-making happening from the community members. And what's kind of crazy about that is that we're expecting community members, the affected population, to grab a hold of the intervention that we're designing for them without them. And community governance really erases that. It allows us to really center the community needs by hearing community voice. And the community information exchange is designed to not only do individual care planning, but also understand that those individuals are part of a community, and how do we use that data in an aggregated way to allow community members to advocate for what's needed, what the priorities are within their respective communities, what the disparities are in their respective communities, and also understanding what the assets are in their respective community. Doing this and centering the experiences, needs, and perspectives of the historically underinvested and historically underrepresented allows us to have a community information exchange. So I'm gonna go to the next slide. And I will not be going through all of this, but we're really looking to use a model like this to change the state of social need interventions. And it really boils down to some of the points that I made earlier about proper representation of the people who are most affected. We're focusing on resource connections instead of root causes. We align our interest in measurement with the institutional power. And so how do we shift that to have a co-developed community agenda to explicitly call out and illustrate the role of structural racism and inequity within a local context? And then also making sure that we're establishing our measurement strategy, so the value case around community interests. Next slide, please. So this is the current situation at hand. So we are now partnering with a lot of the 211s within the Bay Area. And we started noticing that although they're under the label of 211, there's some connection, but they're all really individually based entities. And I think that there's some advantages for that, but also we saw that there was some competitive advantage by partnering with one another to understand the needs at a regional level. We also started engaging with groups like 1 Degree, which is another information referral platform, to understand what was happening outside of the 211 space. And what we were really trying to do was couple this kind of client level data warehouse that comes with screening and couple it with the community resource database. In doing that, we wanted to also talk about what is the shared ownership and governance structure of the community resource data look like? Because ultimately we know that this data should belong, or a community should have some say in the data that's collected upon them, that's present within their community. And these organizations were willing to say, okay, how can we partner together, especially in this time of COVID, which is highlighted that, hey, everything that we're doing should not be done on an individual level. How do we partner up to understand how we can achieve a community information exchange? Next slide. So that allows us to think about a regional approach to data sharing that allows us to better engage community-based organizations, FQHCs, and ultimately community members and caregivers. And knowing, especially in the Bay Area, that people live, work, play in different areas, how do we leverage what data we're seeing in one community and understand how it's impacting another community? Especially when we think of issues like housing and gentrification that's pushing more and more people outside of the places where they work. They may want to live close to where they work, but they don't have the means to be able to do that. And looking at these information referral organizations, we're able to understand what are best practices around the community resource data collection, around the maintenance, around the management. And we're also able to, again, see how we can leverage new collaborations. So how are we taking what we see in the data and partnering with community-based organizations, FQHCs, and ultimately community members to say what is needed, what type of partnership is needed to address the needs that we're seeing in real time. So this is the approach that we're undertaking now. The first step that we're really focusing on is community governance. And that build requires us to really think through how community members access or have access to data. We also have to think through community-based organizations that may not be invited into the room. So we started learning that partnerships typically are held between institutions and CBOs that have more resources. How do we do capacity building with groups that target historically marginalized, historically underinvested groups, so those voices and those needs are elevated? And lastly, I think the great thing about focusing on community governance allows us to really think through how do we share power between institutions and CBOs, and also CBOs and community members. So this is the work that we're doing currently. We're really trying to think through how do we use various partnerships to steward social determinants of health data in an equitable way that uplifts community. Thank you.
All right, so now we'll hear from,
go
ahead.
So next slide, please, and then Lynn, you can kick us off.
Okay. Hi, everybody. I'm Lynn Salazar-Wadford. I'm the Director of Care Management at Piedmont Health Services, and we're based in Chapel Hill, North Carolina. So PHS is a healthcare system of approximately 12 health centers, 2 of which are all-inclusive care for the elderly centers. Our centers are based in 4 counties here in central North Carolina, but we serve folks from approximately 14 counties. And we've got about 47,000 unique patients at this time. And we accept Medicare, Medicaid, private pay, and self-pay patients from these communities.
And hi, my name is Jen Costello, and I have just stepped away as Director of Strategy and Planning from Piedmont Health Services, where I had the pleasure of working with Lynn and many others. And I'm an independent consultant, but I'm sticking with a project that I was working on when I was at Piedmont called Embrace, and that's what I'm going to be talking about today. And I'll tell you a little bit about that later. Next slide, please. So today we're going to touch on social determinants of health strategies that PHS has employed before and during COVID, and give a couple specific stories and anecdotes that we've seen there, talking about those experiences at the clinic level and at PHS's organizational level. And then we're going to talk a little bit about Embrace and how we're approaching social determinants of health there in our cross-sector partnership in Chatham County, North Carolina, which is one of the counties that Piedmont has a couple community health centers. But what we want to point out is that, like the issues of trust that Arter discussed, regardless of when or where or what, every approach that we are taking relies significantly on relationships at multiple levels. So next slide, please.
Okay, so like Jen said, it really involves a lot of relationship building at a variety of levels. So at PHS, our care managers have been the main folks administering the PRAPARE to our patient population. Now with COVID kind of coming on the scene, we have expanded our care management team to include several other staff members from other disciplines to do a more wide approach to our population and be able to administer the PRAPARE more widespread. So initially when we did the PRAPARE, our main focus had been our Medicare population, our prenatals, and any patients that identified a social determinant of health need. So for the most part, PRAPARE functions as a helpful tool that opens the door for our care managers to have a more in-depth conversation. In my experience, it's been most useful when you can administer it face-to-face with a patient. But like I was saying, recently PHS has had to pivot due to COVID, and we've been doing a lot of telehealth. So we've been doing a lot of PRAPARE implementation over the phone. Let's see. So we really feel we get our best results and our most truthful answers from patients when we can have a face-to-face interaction, and when that patient has a relationship with a staff member who is administering the PRAPARE. A small example would be a time that I was able to chat with a woman who just had come in, brought her newborn for the newborn checkup, and we went through the social determinants of health screening together. She didn't identify any needs at that time, and as I was thanking her for having that conversation with me and answering the questions on the PRAPARE, I was getting ready to walk out the door, and she asked me, do you think I should apply for food stamps for my child? And do you think that would affect me in regards to public charge? So we could see here that PRAPARE was open that door for that conversation. And obviously I sat back down. We talked about her concerns. We talked about what she wanted to do, and I gave her the best information that I could. And I hope that allowed her to make the decision that she needed to make. We also talk about relationship building with community and our community partners. PHS, we've been really fortunate to have these relationships already with a lot of our community partners pre-COVID. Care managers spend a lot of time making community referrals. We talk to the same organizations, we talk to the same intake folks, and we've had some really great partnerships in the community already. So when COVID came about and PHS was asked to do some COVID mass testing, we could use those relationships to ask our partners, what are you doing? What do you see as needs for folks in our shared communities? How can I most easily refer patients to you? How can you refer your folks to us if they don't have healthcare providers, they need COVID testing? So that's something that happened, and that happened during our COVID mass testing. And then we continue to do relationship building within our organization. So I think anyone that works in healthcare knows that healthcare providers across the board, I think they have a small amount of time to share with a patient. They're trying to help them the best that they can. One of the beautiful things I think we see here at PHS is that we have several disciplines under one roof. So we don't just have medical providers, we have behavioral health, we have pharmacy, we have WIC at several of our locations, we have care managers. So the provider most times tries to discuss patient health goals briefly, but it really depends on their support staff, for example, care managers, to kind of spend extra time developing relationships with the patient, talking to them, hearing what their priorities are, what their barriers may be to care, and trying to help the best that we can to get the patient the resources that they need, and also understand what their priorities are. I think we could go to the next slide.
Great. So Embrace is a partnership, like I began to say at the start, with the Chatham County Public Health Department, with PHS, and with the University of North Carolina Critical Access Rural Hospital down in Chatham County, as well as the DSS and local community organizing and equity organization. There's no way that we could have developed this cross-sector partnership unless there were strong and trusting relationships already in the community. The intention behind Embrace is to take those partnerships and really build on them, but mostly build on them with the guidance, participation, and leadership of the community. Chatham County is one of the healthiest in North Carolina. It hits the top among North Carolina's counties on several health measures, but it has significant disparities by race, particularly in birth outcomes. We have low birth weight rates among Black women that are more than 2 times higher than they are for white in the county. We have life expectancy that is 5 years shorter for Black county residents compared to white residents. So the benefits and the great things about the county are not equally shared. And so I'm not going to be saying in this presentation anything that we haven't heard regarding social determinants of health and equity that we really haven't already heard from Eureka and Arter and Lynn. But I'm going to describe a little bit about what Embrace is doing specifically. We're of course coming into this far along into a long history of structural racism, particularly in maternal and child health, and particularly in the South, where midwives especially were kicked out of the system. And we are trying to kind of confront some of that with some of the issues and address the disparities that we're seeing. To go back to what Eureka said about the social risks not happening by mistake, it's been the philosophy of Embrace that the changes must be led by the community because the community is not what is broken, it is in fact the systems. And so we really were lucky to pick up Embrace at a unique time when there was a new family medicine residency at one of the sites in Chatham County at Piedmont Community Health Center there, where folks are going to be training at the Community Health Center and then also at the hospital that was opening a new maternity unit. So this new hospital unit going against trends when most other hospitals are shutting down in rural areas, they were expanding and opening a maternity unit. So we took this opportunity that doesn't come along very often to really kind of take a look at the systems and better align the services and the systems with the guidance and the governance of the community. So in terms of our relationships, our main focus originally was, of course, engaging with the community. And I see that there was a question about how that's being done under COVID. Lynn spoke a little bit to that in terms of telehealth appointments. We had to take a step back. Our number one step originally when we were funded in January was to engage with listening sessions with community members, and through that process identify women who would like to sit on governing bodies with this effort. That had to be put on hold under COVID, unfortunately. And so we spent the last few months kind of pivoting and trying to figure out how best we're going to hold those sessions. But in the meantime, we were able to reach out in terms of social determinants of health. We were able to reach out to prenatal providers in the county and say, what tools are you using? What domains are you addressing in those tools? What needs are you seeing among the pregnant moms and families who are coming in to see you? And are you able to refer to those needs? So we're starting to gather data on those issues so that we can kind of start to see. But our focus in asking about social determinants of health is not to bring people into more services at what is a broken system, frankly, that has neglected and mistreated them, but instead to build trust and relationships and try to figure out what's most needed. And so when we look at how to prioritize social determinants of health, we are trying to do that through an equity lens and understand which domains of social determinants of health are most impacted by, if we adjust those needs, which of those best mitigate the impacts of racism and other discrimination. And so in order to do that, we're directing relationships also with the community in terms of connecting with those organizations until we're able to hold our listening sessions. We are also connecting with the organizations that serve women, and we are indeed expanding our relationships. We're finding that there are partnerships as collaborative as Chatham County was. There are, of course, lots of folks that we were not reaching whom we should be. And better understanding how to access all the women that we would like to invite into this conversation if they're interested. And one of the main things that we're doing within our organization in terms of those relationships there is making sure that we all have a shared understanding of our role in health equity and in the system, and how best to kind of overcome the system's errors. And so we've conducted an equity assessment of all of the organizations in our partnership to best understand where they are in their equity policies. And we're going to bring those data back. We're just in the process right now of bringing those data back to our systems to inform them how best to take the next steps to ensure that that we are serving everyone as they deserve to be served. And so that kind of wraps up what we're doing at the cross-sector partnership, engaging with all of the partners that are our embrace. And there's a lot more to come because we're still in only our first few months. So thank you so much for having us, and I'm happy to entertain any questions.
Thank you so much, Jen and Lynn and Arter and Yuriko, for really setting up the stage. I want to encourage the audience, if you do have questions for any of our previous speakers, please do use the Q&A pod. We do see some trickling in the chat box as well. But in the meantime, I do want to, just get the conversation started with our, again, guest speakers, really talking about some of the upstream policy changes that need to happen to really redesign the system. And I think Jen, Lynn, and Arter really hit that point about, we need to really address some of those structural and systemic barriers in regards to racism and just health inequities. So I want to pitch this first question to Arter, given the regional approach in the Bay Area in California and how that community information exchange is really going to set the bar for interoperability and data sharing. How do you think that data, once you really comb through it, is going to lead to some of those more upstream policy and systemic changes that focus on prevention and addressing SDOH?
Yeah, so great question. One thing that we're seeing is the need for policy change at the local level. And oftentimes we think about, especially in California, I look at my ballot and there are so many measures that I have to comb through to understand what policy change are we trying to push for. But with COVID-19 and the conversations we've been having within Contra Costa and other counties within the Bay Area, there's such a need to address, local policy. And so having tools and having data that allows individuals to advocate within their local context is something that has been a gap and something that was very much needed at the height of that first wave of the COVID-19 crisis. And so that's something that we're pushing for. We're also not just looking for advocacy efforts at the traditional policy level. We're really also trying to shape the sector. And so when we look at funding mechanisms for social determinants of health interventions, they don't necessarily reward community-centered, community-based practices. I talked earlier about the fact that a lot of the measurements are around the healthcare system and not the community. And we want the community to adopt and accept these social determinants of health interventions, but we're not understanding the value case and the measures of success from the affected population. And so those two lessons have been the biggest, or the central pieces that we're thinking about when we talk about policy change. So the local level, but also really thinking through influence in the sector as well.
Thanks so much, Arter. And I love the perspective on bringing it back down to the local perspective, which kind of gives me a segue to Jen and Lynn in terms of what you're doing out in your neck of the woods and that cross-sector partnership. Lynn, you mentioned that you're working across 14 different counties and that there's so many different stakeholders involved. And Jen, you mentioned that too. What kind of upstream prevention policies are you seeing happening in your local context right now? And how is that data potentially incorporated for SDOH?
So I think that it's hard, you asked the question about how patient level data are being used to inform those changes. And I think that we are all still struggling to get to the point where we have enough robust data, and perhaps we're waiting for the enemy, or what is it? Perfection is the enemy of good.
Yeah.
That being said, what we're trying to do is, because we understand that the collection of the data in those offices, in those exam rooms, doesn't always happen, or doesn't always happen as completely as we would like. We are doing our best, and again, COVID interrupted this process, but going straight to the community members and the moms and the families to ask them what have their experiences been with referrals to social services. What did you find? Tell us about your pregnancy. What kind of services did you felt that you need? Were you able to access them? Were they brought to you in a way that was meaningful and respectful and with dignity? And that's where we're gonna go straight to them for part of this in terms of guiding what we do in terms of the wraparound services, and then also crosswalk those with the data that we found from the prenatal providers, including PHS, to understand what tools they're using so that we can kind of identify what the gaps are.
Great, thanks, Jen. And for Lynn, yeah, any perspective on kind of how that data is going to be potentially used for more of the upstream policy change on a local level for the health center?
Well, similar to what Jen said, it's been really difficult since we can't see patients face to face, and we don't have the luxury of having conversations with them and hearing directly from our patients in the way that we're used to doing it. That being said, all the health centers have started to do quite a few outreach calls to our population in general, checking in, asking them about their chronic conditions, asking them about their needs, seeing if we can do something as simple as sending in a phone note with a med refill request. So when we have the chance to do the PRAPARE form with our patients, in our system, every answer is connected to an observation term. So we can then gather that data and help use it to promote better policies and more access and more needed services for our patients. The services that our patients are asking us for, the barriers that they constantly tell us that they're running into. I hope that we can use that information to push things forward in North Carolina.
Thanks, Lynn.
I'm sorry, Albert, can I add one thing? I just realized as she was talking that one thing that we've noticed is that, for example, the Chatham locations of Piedmont Health Services sit south in the county, pretty close to another county line. And so some of the services, nurse home visiting, some of the high-risk pregnancy care management services that can be only provided by Chatham Public Health Department to Chatham residents become useless, because a lot of the patients who are coming from different counties in order to see patients at Piedmont Health, for example, can't be served through those services. And so it's with those realizations and those data that we're trying to find regional funding streams so that we can provide those services regardless of home location, for example.
Thanks for that additional comment, Jen. Yeah, and that kind of goes back to kind of the approach that our chair was speaking about in the Bay Area, and taking a really regional approach and seeking out other partners and stakeholders in your local context. So thank you for sharing that. I'm gonna address this question from one of our audience members, and going back to Lynn and Jen, since you work closer to the ground with the patients, how are you engaging your most vulnerable patients during this pandemic and the economic downturn? Are you doing any incentives to get them to talk to you and really engage with you, given all the different stresses and external factors involved?
You go first.
Okay. Well, like I was saying before, it's difficult to engage the community when the safest thing right now with this COVID crisis is to not be close to each other like we're used to being close to each other and not having those face-to-face conversations. So it has been a struggle. We unfortunately can't really offer our patients any incentive to chat with us, but we try to be available for patients who want to talk to us, whether they bring it up in a telehealth visit with their providers. Our care management team have Zoom accounts, so we'll be happy to do a Zoom meeting just with us and the patient and talk as long as the patient needs to talk. If that's a viable option for the patient, we know sometimes that's not an option. A patient doesn't have a smartphone or a tablet or minutes on their phone. We have started to do some limited face-to-face interactions, trying to take as many precautions as we can for ourselves and for the patients. Most of our offices are pretty small, so we try to utilize larger meeting areas in our respective clinics. And then I think we also really count on our community partners, because in some of the meetings that we have the pleasure of being in with our community partners, we can people ask us questions. So there's a large group of community health workers in Orange County, North Carolina, and a lot of times they are getting these direct communications from clients and patients that we share. So they can ask me directly, hey, this is what so-and-so told me about the clinic. Is it really true that you guys are doing this? And I could say, well, this is what we're doing, and this is how this person can access me. Or, we could problem solve together, even if I can't talk to that patient directly.
Thanks. And
Go
Jen,
ahead,
if you want to add, or Arter, yeah.
And I know that this presentation did not necessarily go into like community engagement, but we do some of that work. And I really appreciate the notion of, a lot of times we ask community members to inform efforts, and that's the way that we're engaging with community members. What we have seen, especially during this time in partnering with health systems, is that we have to talk about, the ownership that the community member can have, that they actually see their work translated into results or to some type of action. And we've seen that framing help people become engaged even in this time. And we do have to do extra prep work during a virtual setting. So actually yesterday we were talking about housing insecurity in the rural counties of California. And so a lot of the issues that are coming up in this question between internet and data plans came up with these community members. And so we had to have several touch points to make sure that we understood the needs and what resources they needed to be able to engage. We also had to make sure that as we were prepping for the meeting, that people are actually seeing some of their individual thoughts connected and formed in our actual meeting. So they need to see their words in the meeting. And we were very fortunate that with this health system, we were able to give an incentive. We were able to compensate, I think in the form of gift cards to individuals. I think the trick with that is when you're talking about compensation of community members, it's really important, especially as you're addressing the needs of the affected population, that, we're in a messed up system, and the fact that sometimes there are barriers that come with people who have certain benefits being able to receive funds, because it can throw them off of receiving a full benefit. So we have to be really careful and mindful of that, to understand that the compensation actually matches what they can receive and what they feel comfortable receiving with the benefits that they have.
Thanks so much, Arter. And I am just looking at time with 2 minutes to spare. Is there any last minute kind of piece of advice to our audience today, who are a mix of health centers and CBOs and health system partners? What's your piece of advice to really start developing those relationships? Like, what's one tangible thing that these people can do tomorrow in order to establish that? And I'll start with Lynn.
Well, I think one tangible thing that we can do now is, I mean, have a meeting, have a virtual meeting. I mean, I don't love to have another virtual meeting. I think we're all a little bit tired, but I mean, I think so many of us do work that's very close, the borders touch or cross, that in my experience, folks have been super receptive to like chatting. How can we not duplicate services? How can I help you? How can you help me? How can we do the best that we can for the community?
Good tip. Thanks, Lynn. Arter, what's one tip you'd share with the audience?
Yeah, I think we have to admit harm. I think that we really need to start off by saying, intentionally, unintentionally, we've created or participated in systems that has created harm for different communities, and really own up to that. And I think I have found, especially in the work that we're doing, being able to admit that harm and saying, hey, we want to correct that. And the only way that we can correct that is with you as the community. We need your voice. And I think coupled with what Lynn has been saying, the urgency of the time, coupled with, being able to say, hey, we messed up and we need to do things differently. We need to, change the way we engage with community. Your voice has to be centered. You have to see your voice. We need to make sure that we're addressing the power structures in our room. So, institutions have to think through how they're connecting with folks because of the power dynamics in the room. And we're calling on, large health systems to think about the power constructs that they have with FQHCs to think about the power constructs that they have with their patients, community-based organizations with their clients. And that's really bringing people to the room. So that's something that I think that people can start doing tomorrow, admitting harm.
Thanks, Arter. A little humility goes a really long way. So thanks for sharing that piece. And Jen, could you close us out with, your one tip from your perspective?
I don't think I should. I think it's all been said. I appreciate the perspective of my fellow panelists. I think humility will go a long way, and I think we all have a lot to learn about that.
Thank you so much. So I am going to close this session out with just some quick next steps. So you guys will be getting the recording from Zoom on an automated basis within the next 24 to 48 hours. So please be on the lookout. And we'll be announcing a set of office hours for this webinar series soon to come in your inbox. And please complete the session evaluation that we're going to launch. It's just a quick Likert scale, 3 questions, just to let us know how we did. And please also at the end, if you have time, share some topics that you'd like us to address in a future webinar series as well, since this is going to be a pause for the November month as we recalibrate and replan. So with that, just want to thank again Arter, Lynn, Jen, Eureka for this hour on a Thursday. We know it's before Halloween, so want to wish you all a safe and fun weekend if you can manage to get out and just get fresh air. And thank you so much and have a good rest of your day. And there's resources in the handout, just by the way. So these have been incorporated in each slide deck. So take care, everyone.